Um, Representative Ballard, we're starting the meeting. So we do have a full agenda. Actually, as I mentioned yesterday, we're going to be talking about a lot of Medicaid items. But the first item on the agenda, are there any bill introductions this morning? All right, seeing none, we'll go ahead and move on to the first item on the agenda. And I would just kind of like to preface that this kind of came about. I've been attending the Medicaid Leadership Academy for about 4 years in Washington, D.C., and this was one of the items that we discussed this past fall when I was attending the meeting, and I thought it was kind of interesting, so that's why we have it as a item on the agenda. And so right now we'll have the tele-ultrasound technology with Ryan Fuller, the manager of the Ultrasound Clinical Solutions. Ryan, are you on WebEx?
I am here. Actually, I'd like to introduce my colleague first, Jennifer Law. She'd like to open the discussion from Phillips, and then we can move to the ultrasound piece.
That is perfectly fine. Proceed.
Thank you.
I'm sharing my screen right now. Does this look all right to everyone?
Yes, we can hear you.
Okay, terrific. Chair Waymaster and respective members of the committee, thank you so much for this opportunity to share with you the urgent state of maternity care and how technological advances can help improve access to care. My name is Jennifer Law, and I am the Maternal Health Partnerships Lead at Philips Healthcare Technology Company, and we have a very broad maternal health portfolio and a particular legacy in fetal monitoring and ultrasound. So I'm going to start off by telling you about remote fetal monitoring, and then I'll turn it over to Ryan Fuller, my colleague, who will tell you about tele-ultrasound. So I want to start off by highlighting the trends that are compelling the way that we're thinking about maternal health and that are informing our technological innovations today. Every year in Kansas, 35,000 mothers give birth. But there are two trends that I think we all need to be aware of. The first is that there is an increasing number of complicated cases. So pregnancies are becoming trickier and trickier. Now, a quarter of pregnancies are considered high risk. And this is due to things like advancing maternal age, incoming conditions such as obesity or hypertension, and just overall, we're seeing more complications happening in pregnancy. These complicated pregnancies are what is driving cost in our system. Studies have attributed it to about 50% of our pregnancy care costs in the United States. And at the same time, access to maternity care is decreasing. There is a huge OB shortage. It's true not just in Kansas or in the United States. This is a global phenomenon. And now almost half of Kansas counties are considered maternity care deserts, according to the March of Dimes, and that is defined as a county with 0 birthing hospitals, 0 OBGYNs, no obstetric providers. So this is a bad combination where we have mothers who are in more need of medical care, and it is harder for them to get care. And together, these are contributing to maternal fetal outcomes that are just the worst of any industrialized nation. The United States ranks 33rd out of 36 OECD nations in terms of global infant mortality. This is below Poland and Slovakia. Do better. COVID pandemic showed us the potential for telehealth, but telehealth has been slow to move to maternity care. And I'm here to tell you about the technological advances that enable clinicians to now monitor fetuses remotely. So to understand this, I'm going to tell you about a key obstetric procedure, which is called a non-stress test, or an NST. So an NST is actually very simple procedure. It's a monitoring procedure. You ask a pregnant woman to come into the clinic. She lies down, and for 20 minutes, you have 2 transducers on her belly, and you're just looking for a reassuring heart rate. This procedure, in combination with the ultrasound, are the 2 main tools that OBGYNs have to ensure the health of a fetus. So the challenge with NSTs today is that because they can be prescribed so frequently for high-risk mothers, and when I say frequent, it could be every few days. Up here on the slide, I show that the ACOG guidelines, and ACOG is the American College of OBGYNs, they recommend up to twice a week for the last 8 weeks of pregnancy. So you have 16 extra appointments to come in for an NST. And that is asking a huge amount on the pregnant woman who has to take off time from work, has to find childcare, find transportation, and particularly in a rural state like Kansas, drive potentially over an hour just to receive this procedure. So no-show rate for NSTs is very high, 28 to 30%. We've heard it worse in other places too. And that's a real shame because monitoring it's not a diagnostic procedure. It's a preventive procedure. We're trying to pick up issues before they become emergencies. But I totally understand it from the perspective of a pregnant woman. If you have gone for 10 NSTs and they have been great, are you going to make it to the 11th one if it's really inconvenient? I can understand why they. So I thought the procedure and offer a remote, and that would open up, so for the mother who is no longer burdened by having to travel into the clinic. She's able to be seen at a time that's convenient for her. Clinicians are excited about it too because they too are overburdened with the number of pregnant women coming into their clinic and running late or missing their appointments. So it makes things easier for their workflow. But ultimately what we're here for is improving outcomes. Monitoring is an inexpensive way to catch issues before they become emergencies. So this is an solution for remote non-stress test looks like. There are others on the market. This is how what we're working on. So you'll see a belt that is self-applied, and it is FDA approved for self-application as well as for non-stress tests. And then you can see that she's looking at her phone because on the phone she's seeing the data that is coming in. This is this slide shows what the workflow could look like for remote fetal monitoring. So if a OBGYN thinks that you're a good candidate for remote fetal monitoring, then the device would be shipped directly from the manufacturer to the pregnant person at her home. She would download an app on her smartphone, pair it with the device, and then perform some virtual training to make sure that she understands how to apply it and that the signals are working. And then at her scheduled virtual appointment time, the belt goes live and the clinician is on the other side, but not really there. The clinician is at the clinic. And then the clinician will see live tracings of the fetal heart rate and the contractions. So this is exactly what they're accustomed to seeing in the hospital, but the mom is not in the hospital. And then afterwards, those results are sent to the EMR. There are two key points I want to highlight from here. From our perspective, it's important that remote fetal monitoring is something that is done by prescription only. Providers are very upfront with us saying they don't want moms just, running their own tests and sending them data that they're liable. So mom can't raise, I'm anxious now. This is something that is initiated from her doctor. And at the same, also, this is more akin to a virtual telehealth appointment than it is to continuous monitoring. So she's not wearing this belt for the last 8 weeks of pregnancy. She's only putting it on whenever she has a scheduled non-stress test appointment. She puts it on for 20 to 40 minutes and then afterwards takes it off. I think stories make technology come to life. So I just want to briefly highlight how Banner Health in rural Colorado used remote non-stress tests. They had a challenge where a lot of their pregnant women were traveling over an hour to come into the clinic. And at the same time, they felt like they needed to prescribe more and more NSTs because their patient population was at risk. And it was challenging for their patients. It was challenging for them too. And so I have a quote here from both a patient from Banner Health as well as from Dr. Blake McLaughlin, an OBGYN. He actually runs the practice there, and how, from his perspective, this was a real tool for empowerment and just giving the option for people to have the same care that they're used to. So what can you do about it? We have a simple but a very important ask. NSTs are covered by one CPT code, 59025. But this code doesn't say anything about place of service. It's completely ambiguous. And providers are really excited about remote vital monitoring, but they always go back to the reimbursement, and they're like, they don't want to be on the hook for the cost of this. So our ask is that you consider issuing guidance or some kind of legislation that clarifies the reimbursement coverage for remote NSTs, as long as the same standard of care is met that you expect in the hospital, but that would be delivered at home. So with that, I will turn it over to Ryan, and then we'll open up to questions. Thank you very much.
All right, thank you, Jennifer. Ryan.
Thank you, Jennifer and Chair Waymaster, respected members of the committee. Thank you for your time today. My name is Ryan Fuller from Philips Ultrasound, and I want to spend some time talking to you about ways in which we're using technology to expand remote access to care in ultrasound. Jennifer talked about working in the monitoring phase of it with NST. I want to talk about ultrasound and how we're working to expand access moving forward. And as you know, ultrasound's been used in many different ways in and around pregnancy for many years. And I want to talk about some of those today just as a reminder. Then I'll introduce you to a couple of ultrasound systems that we've worked towards to help expand access by making them more portable and improving the performance of these smaller based ultrasound products. And finally, I want to talk to you about a communications tool that links it all together between the system and more experienced caregivers. So let's talk about ways in which we use ultrasound in and around pregnancy. Now, these are pretty common to you, I'm sure, but I'll just highlight them. When we're looking to do an ultrasound in pregnancy and look at the fetus or the environment around the fetus, there's many ways we do it in different times of pregnancy. It might be during early OB dating, where we're understanding that there is a viable pregnancy and we want to see how far along the fetus is. Genetic dating, and when we're looking at maybe something like nuchal translucency imaging for high-risk patients. We do anatomic surveys of the fetus itself, where we're trying to look at and make sure that there are no obvious anomalies to the fetus, and check the environment of the pregnancy in and around the uterus. And then you might get to level 2 or higher level ultrasounds where we get maternal fetal medicine involved, where there are suspected anomalies or a high-risk patient type. And finally to labor and delivery, where we're actually going through the process of delivery and want to track that process visually with ultrasound. One thing that we don't think about in pregnancy is ultrasounds we might do out on the mother during pregnancy or after. And these could include GYN exams, abdominal ultrasounds of the gallbladder or kidney, cardiac ultrasound, vascular ultrasound, including DVT studies, which can be pretty common during pregnancy, as well as emergency ultrasound when a patient is in distress. So these are ways we utilize ultrasound today, but how do we get it, meaning the ultrasound system and the user or experienced users, in front of patients who can't always get to a local community center, local office, maternal fetal medicine office, etc. And in rural areas, of course, as Jennifer mentioned, that could be more and more challenging. And so as a ultrasound innovator, which Philips is, we looked at ways that we could apply ultrasound technology to allow for more expanded access to care. And I'm going to talk about two systems that are newer to the market in ultrasound that allow us to do that. One is a type of device which we call ultramobile ultrasound. This is a device you can put in your pocket and you take it with you where you want to go. Very portable, very mobile. Typically doesn't have the diagnostic capabilities of our cart-based systems. The cart-based ones are the ones you see in OB/GYN offices, maternal fetal medicine, et cetera, in hospitals. But it really gives us great access to care and very quick information of what we need to know about the pregnancy. The other type of ultrasound, I'm actually going to talk a little bit more about Lumify because it's kind of unique, so we'll expand on that just a little bit. The other type of ultrasound I want to speak of is what we term luggable or compact ultrasound, and introduce you to a 5000 series compact from Philips. This is a system that takes higher level technologies and more cart-based style technologies, but brings them into a smaller system so that if I want to go and take care somewhere else, I can put this in a suitcase, roll it to where I want to go, and have those better diagnostic capabilities available to me, including better image quality, performance, and advanced capabilities such as 3D, 4D, and the ability to hook up and do your reporting as you see fit. This system is the one that typically you're thinking about in ultrasound where, as like I said, you go to the OB/GYN office, you go somewhere else. They typically have a level of system like this or better. Let's talk a little bit more about that ultramobile device, because this is sort of unique. And what it is as you look at the person scanning here in the picture on the left, you'll see them holding a transducer in their right hand. That's what we utilize to scan the patient. It's what we put the gel on. And inside that transducer is where we put what we call the beamformer of the system itself. That is what creates the image itself, the technology and hardware necessary to do an ultrasound image. And we actually took advantage of a lot of higher level technologies from our premium level products to do this, but we're able to miniaturize that to that transducer. Then we connect that transducer to your favorite device, whether it's a tablet or phone, iOS or Android, and then connect up and utilize the system for imaging ultrasound. It's very unique in terms of, it's kind of surprising in terms of performance, has some advanced capabilities like the ability to analyze blood flow, as well as fetal environment and measurements of fetal size, and even new advanced techniques such as new quantification techniques available, such as our beeline quantification, which we came out with during COVID to take advantage of the quick AI quantification techniques available to us on the Lumify device. How do I get into Lumify? Well, I download the app in my store. I connect the transducer that I purchased and I'm ready to go. And I can connect up to my PACS if I choose to do that wirelessly, so that I can even save images and bill if that's what I want to do and how I want to utilize the system. And once we're scanning, there's a number of things we can do. Strictly speaking, looking at the fetus itself, we might do measurements, as I mentioned, including early first trimester measurements such as crown rump length and mean sac diameter. We can do Doppler measurements, which is assessing blood flow in the fetus and the placenta, and even the mother if need be. Very important for understanding health of pregnancy. These are a little more advanced techniques, but some of the simplest things we can do is actually just look at fetal environment. And there's so much information we can get by just looking at the around the baby, understanding the lie, understanding the amount of fluid, looking at the placenta, or is the baby just moving? There's a lot that can be understood just by doing that. And a lot of understanding of health of pregnancy comes the moment you put that transducer down and start looking inside the uterus. Now, what happens though, if I'm scanning and I get an issue, or I'm not as experienced a user and I need some help, and I'm out exposed on my own in a small imaging center or local community center where I'm offering this capability, and I want to reach out to my more experienced users? Well, we tackle that with a software that we call Reacts, which is a telecommunications software. It allows somebody on a device, whether it's a Windows device, Android, iOS device, and they can connect up to the ultrasound system. And when you're connected up to the system, there's a number of things you can do. You can share screen, meaning the image itself. You can do text chat, audio chat, video chats as well. And you're actually seeing that on this screen as well. What's happening here is the patient's being scanned. They're sharing the screen. This is actually the screenshot from a Windows computer of a user somewhere else, could be anywhere in the world. And they're actually looking at the screen live in real time, watching the scan happen. They're in fact looking at a carotid here, looking at blood flow in the carotid artery. They're actually sharing a camera on the system to see where they're scanning so they can maybe help guide whomever's doing the study. And you see at the bottom, you can see their cameras there of the person talking. They could actually come on there and talk to the patient as well, maybe consult with them or just ease their mind a little bit in terms of what we found in this particular study. You'll also hear me sometimes speak of Collaboration Live. Reacts is a software. Collaboration Live is available on our cart-based systems. And what Collaboration Live does is all those things that I just mentioned, but also includes the ability to take remote system control. So I can actually control the system itself from wherever I may be. Maybe I want to assist with an exam. Maybe I want to help them turn on Doppler and assist them in optimizing it. And I can do all of that live and in real time. So the idea, again, with all of these is how do we take ultrasound, something that's been used in and around pregnancy for a long time? How do we take new technologies, make optimizations, and create new and unique systems to allow us to be more mobile with that ultrasound, still getting excellent quality while we're doing it? And are there ways that we can communicate better with the ultrasound system to help assist and collaborate on all of the studies we may be doing, even if we're not in that local center of excellence or center where we might typically do the imaging? So with that, I thank you for your time. I want to pause. I'll stop sharing, but please, Jennifer and I are here to answer any questions you may have, and I'll open it to the floor. Thank you.
All right, thank you, Ryan, and thank you, Jennifer, for being here. And actually, just to kind of elaborate, I was intrigued by this because I live in a rural part of the state of Kansas, and when my wife was expecting our children, the closest OBGYN what we had was an hour away. And so, especially during the last pregnancy with our twins, she had to go twice a week to Salina in order to see her OBGYN to have an ultrasound. And so when we had this in the Medicaid Leadership Academy, that's why I was very interested in this remote ultrasound. So the first question that I have is for Jennifer. And what was the Medicaid code that would cover this? You said it was ambiguous and it covers it. What was the code number?
Yeah, the code number is 59025.
59025?
That's right. Yeah.
Okay. And, you know, looking at the map on when the presentation that you had, I think it was the last slide, we see that in our region, the state of Missouri has had recent guidance or law about remote NST or remote ultrasound. And there's only 3 other states. Why hasn't more states in the United States taken advantage of this?
I wanted to put that back up. Hopefully you can see this. It's a fair question. So this is honestly, you know, we're on the forefront of new technology here. So our solution received FDA clearance in 2021. So we're talking about things that are really new to the market. I will say that Europe is like decades ahead of us, and they're farther along with remote fetal monitoring. So I think what we're seeing is we're at the beginning of this wave. Missouri, Ohio, Pennsylvania have already gone out and clarified that remote non-stress tests can still be reimbursed as long as we're meeting the same standards of care as a in-clinic non-stress test. And we're really excited that a lot of other states are starting to see that as well. But right, that's my
I could add to that as well from the ultrasound standpoint. Same thing with ultrasound technology. The development of these new technologies to miniaturize and also the development of these new telecommunication tools has sort of been in line. COVID gave us all moved us in a certain direction, but I think it's also allowed us to, you know, it takes time to do these developments. So I think you're seeing a culmination of need as well as technology coming forward at the same time.
And so we talked about the Medicaid code, but is this covered by private insurance?
Yes, that it is, absolutely. So in this forum, we've really been talking about Medicaid, and that's what I'm referring to in this slide here. But yes, we also have examples of private insurance companies who are also clarifying their guidance around reimbursing remote fetal monitoring.
And the same would hold true of ultrasound, depending upon that you provide specific information and images and reports to it. The same would hold true. It's going to, you know, can change based upon insurer, but that will hold true with ultrasound as well.
And is this utilized just for the first trimester or the entire pregnancy?
It depends on what you're looking to do. First trimester is that moment where you want to assess, you know, fetal health, how old the baby is there a heart rate, how does the environment around the fetus look. As you get further along, you can see more. It depends on if you want to. So if you For example, in a high-risk pregnancy, you want to make sure that you're getting better views of the fetal heart, and you want to make sure that you're doing those high-level exams. You need qualified personnel to scan and do that, and then you need to do the proper reporting if you want to get paid for that. But that can be done, especially on that compact system we talked about, the 5000 series, much more likely that you're going to get successful exams with that than the ultramobile device further along in pregnancy.
All right, thank you.
And
Jennifer, go ahead.
Sir, I was just going to say, for remote non-stress test, that is only a third trimester. That is only clinically indicated in the third trimester.
All right, thank you. And I guess I'd be interested in seeing what language has been actually in the states that have instigated this with Missouri, Ohio, and Pennsylvania. So if you could provide that language to us. Representative Landwehr.
Thank you. This would be for Ryan. So on the ultrasound, that's a healthcare professional that goes out and does this, or it's done by the pregnant mother?
Currently, the current care level is that is done by a healthcare professional, somebody trained to do ultrasound. Ultrasound isn't a simple exam to do. So having somebody comfortable with doing it is going to be very important, especially with the more complex exams you want. As I mentioned, you can go very quickly and look at the environment of the fetus and assess that, or you can go further in depth with diagnostic studies. Now, I will say that we are as well looking at ways to help improve the ability of the system to support somebody looking on their own, and we want to investigate that. But currently, the current state of care is that is done with a professional on site.
Representative Landwehr.
Thank you. A couple more questions. Is the ultrasound under the same Medicaid code?
It is a different, I'm sorry, I don't have the code in front of me, but there are different codes based upon the type of exam you're doing. So there are different levels of code available in ultrasound based upon when you do the study, the type of exam you're doing, the in-depth analysis that you're doing. Are you using Doppler? Are you doing fetal echo work? All of that is going to change. And these are well-established codes, though, in ultrasound.
Representative Landwehr.
So you're saying that these Medicaid codes today, either the one you're talking about or the one that that Jennifer's talking about on the stress test, allow now for a remote?
Ryan.
The question does come into play on the remote side of it, and I won't say that as a broad statement that that's available everywhere. We do have studies done with users utilizing the remote capability and in getting payments for that, but I can't make a broad statement on that because I just don't have all that information.
Representative Landwehr.
And can both of you provide us what is the cost for each one of these?
Ryan and Jennifer.
So for a non-stress test, I would need to confirm within Kansas, but it is around, I will say, like ballpark, around $50, potentially between $35 and $70 is, so I would put it right at around $50 is my best guess.
Representative Landwehr.
You said $50 on the stress test?
That's right.
Jennifer.
Per non-stress test.
So you think that that's what Kansas rate pays, or that's what's being billed?
Jennifer.
That is, I think, what the Kansas rate is. That is what I will need to go back and verify what it is specifically under Kansas Medicaid, but that is my hunch. That's not
Ryan? Ryan, same question.
Yeah, I was looking at the typical payment for an ultrasound. So if you look at a pregnant uterus less than 14 weeks, it's an approximate payment, but approximately $100 to $120 global payment. That's broken down between the technical fee and the professional fee, who's reading the study, but that's an approximate value.
Representative Landwehr.
Sorry, it's like one answer gives another question. So you think that that's the rate charged for remote?
No, that is the normal rate done in a office-based setting. Yes.
Representative Landwehr.
So I would assume that that's going to be a higher rate for remote.
Ryan?
Yeah, I couldn't, as I said, I couldn't say for sure whether it would be higher or the same. I think the goal for a user, if I'm a clinician, is to get paid as close as possible to that rate. I don't know if they need or are looking for higher rates, but I think the goal is to get as close to that as possible while expanding the access. So I'm not sure. I don't think it's all written out yet, and hopefully, we'll see more clarity as we move forward. But the telecommunication piece could add some dollars, but I'm not sure about that across the board.
Representative
Could I
Howell?
interject?
Oh, Jennifer? Yes.
Is that right? So for remote non-stress tests, our goal is not to have it be reimbursed at a higher rate. We believe it is about giving options. So reimburse at the same rate that you are reimbursing for in clinic, just so that we're giving the option to the physician to prescribe in whatever modality makes sense for this particular pregnant patient.
All right, thank you. Now, Representative Howell.
Thank you, Mr. Chairman. I guess the question could be addressed to either the conferees. Do the providers own the equipment, or is that something that is leased by Philips to the provider? So how does that work?
Ryan?
Can you go first? Sure.
Go ahead, Jennifer.
Oh, yeah. For remote non-stress tests, the feedback we've gotten from providers is that they don't want to be inventory for all of these belts. It could be hundreds of belts within their system. And so we have designed it so that we as manufacturer take care of the inventory. The belts are actually reusable. So after a mother is finished with her pregnancy, she sends it back and we disinfect it, we test it, and then we send it to the next patient. But there are, of course, like different models, but this is what we have heard from providers, that they just don't want to be involved with managing all of the devices. But that's specific to fetal monitoring. Ryan?
Yep. From an ultrasound standpoint, it varies. Some clinicians want to purchase the system outright. Some will lease the system, depending, and do the payments and get the value there of the system while they're making the payments. I will say with the Lumify device, typically we sell that because of the price point it's at and the portability of it. We don't oftentimes do any leasing with that. Although I think as all manufacturers, we're flexible in how we want to work with customers. Sometimes we work with large purchases of that type of product, and maybe there's options that we could identify that could be leased, but typically those are purchased.
Representative Howell.
Thank you, Mr. Chairman, and thank you for that information. Is there any short-term evidence that that has been quantified that these technologies can reduce maternal death rates?
Jennifer or Ryan?
Yes, there's a huge body of a growing body of research that is looking at, if we can offer remote care, what impact does that have on birthing outcomes, which is ultimately what we're looking for. So yes, there are tons of studies. There are a lot of studies that are also based in the EU, I will say. The largest, there was a big one called the Hotel Study that was just in the last couple of years, and it was really looking at so it was actually looking at like hospitalized women who are on bed rest in the hospital, and then giving the option to have them receive their non-stress tests and their ultrasounds at home, and what impact did that have on their outcomes. And it was very encouraging. And additionally, it saved the system so much in cost.
Representative Howell.
Thank you, Mr. Chairman. If I may request additional information about those studies, I'm meeting with the Kansas Birth Equity Network later today, and I'm interested in seeing how perhaps these technologies could help some of the more underserved areas of our state, and just linking that to some of the body of research. Thank you, Mr. Chairman.
Representative Carlin.
Thank you, Mr. Chair. Back with Representative Landwehr's questions about cost. I wondered what the private insurance cost would be and what a cash cost price would be, and how, if you don't know the dollars, how do you compare those We're talking about Medicaid at this time, but this would be available to people with insurance, I assume.
Ryan or Jennifer, do you have a response to that question?
This is reimbursing at a higher rate, no surprise, for the non-stress test. Am I answer your question directly?
Representative Carlin?
I really couldn't understand your answer, so you're cutting out real bad. Just give me a few words, please.
Jennifer?
Oh yeah, private insurance is reimbursing for non-stress tests at a higher rate than Medicaid, and that is true for many procedures, not just non-stress tests.
And I will add to that as well. Typically in ultrasound, we're not seeing self-pay from patients. They're typically utilizing some sort of coverage. So I couldn't honestly say what that would come out as from a self-pay standpoint for ultrasound alone. But I agree with Jennifer on the other part, private versus public.
Just to reiterate, private insurance is a higher cost than it would be for Medicaid. Is that correct?
Correct.
Higher reimbursement. Thank you, Representative Landwehr. Any further discussion in regards to this particular topic? Representative Ballard.
Thank you. I'd like to follow up on a question that the chair had asked. You were saying that you could have it at the beginning, but also you could have it throughout the pregnancy if you thought it was a problem pregnancy. So my question would be, do you have to have a doctor then approve that in order for you to get the funding? Or if you are one of those people that are really concerned and have a history, can you pay? How does that happen? Because that could be very expensive.
Ryan or Jennifer?
So what Ryan and I are talking about are provider initiated. These aren't consumer devices. These are medical devices. So you can't go buy it on your own. You have to have it on the order of a physician. But you're right. I mean, like potentially, like down the road, it could be something that a consumer could go out and pay for. But that's not where we're currently at. And yet, yes, it would be expensive for someone to pay for it on their own. But right now, this is 100% provider initiated.
All right, thank you.
And there are guidelines and goalposts in place, as Jennifer mentioned, for that today.
Okay, thank you, Mr. Chair.
All right, seeing no further discussion, thank you again, Ryan and Jennifer, for being here and discussing the possibility of remote ultrasound and non-stress tests. So thank you.
Thank you for the opportunity.
All right, committee, we're going to go ahead and move on to the next item on the agenda, and that is the community support waiver. And so I'd invite Michelle Hayden, the Commissioner for Long-Term Services and Support with the Kansas Department of Aging and Disability Services. Michelle.
Oh, thank you, Mr. Chairman. Thank you for the opportunity to provide updates on KDAD's work in developing a new home and community-based services Medicaid waiver for individuals with intellectual and developmental disabilities, commonly referred to as the community support waiver. Please note that I will not be reading testimony verbatim, and there is more information in my written remarks. I will try to spell out acronyms as I go because there are a lot of them, but please stop me if you need me to expand. The development of So before we get into the KDAD's ongoing work in areas integral to the development of this waiver and the timeline for implementation, let's take a quick look at the issues that spurred the development of the interim committee's desire for Kansas to develop our own community support waiver to serve individuals with IDD. Current numbers of the 7 HCBS waivers for the KDAD's that KDAD's administers serving the IDD waiver is the largest and began in serving individuals in 1991. KDAD's is currently serving more than 8,950 individuals on the comprehensive IDD waiver with an average cost of $53,244 per person per year. There are currently 5,240 individuals on the waiting list for services. Note that KU Center on Developmental Disabilities is on their second year of studying the individuals on the waiting list, so they can gather more data about the current their current and anticipated needs to inform our work and expand the provider network. The 2022 Special Committee had a number of recommendations, moving away from the basis assessment tool and adopting another tool such as the MFEI or the MIFI, which will be discussed more later. KDADS was directed to provide a fiscal impact statement for potential community support waiver services discussed by the special committee. The special committee also recommended a $20,000 cap per participant per year. The comprehensive waiver, again, has an average cost of $53,244. In February 2023, KDADS provided a fiscal impact statement to the House Appropriations Committee. The estimates provided were based on the range of participants for the CSW, anywhere from 3,600 to 7,461, and can be honed in as KDADS begins receiving results from the ongoing IDD waiting list study being conducted under contract with KU Center on Developmental Disabilities. The waiver would be funded 60% federal funding, 40% state general funds. Projections depend on how much funding would be dedicated to potential new community support waiver by the legislature. Total cost estimates range from approximately $72 million all funds, including $29 million SGF, to $149 million all funds, including $40 million SGF when fully implemented. KDAD suggests an approach in which the agency would work with the Community Developmental Disability Organizations, or the CDDOs, and other stakeholders to roll out the waiver in a phased approach. This would be done to ensure system capacity is not overloaded, ensure appropriate service provision, ensure the waiver is implemented correctly. Like other areas in health and human services, direct care staff worker shortages have been a challenge for the IDD waiver. The governor and legislature have supported funding to increase direct care rates over the last few years, but the success of the new waiver is contingent on having an adequate network capacity. So an example of a rollout would be in year one, we would roll out approximately bringing 500 participants with a $20,000 cost cap, roughly equates approximately to 10 million all funds, 4 million SGF. Year two, we would bring on another 1,000. Cost cap equates to an additional approximately 20 million all funds, 8 million SGF. After hearing the estimates, this House Social Services Budget Committee added a budget proviso in 2023, House Bill 2184, directing KDADS to apply to the Centers for Medicare and Medicaid, or CMS, for a CSW waiver. Today, I'm here to give you an update on work KDADS has been doing in line with that proviso to lay the groundwork for successful application and implementation of the community support waiver. First, though, why a community support waiver? The 2022 Special Committee heard from a dozen states, including many who have some sort of community support waiver, which is generally designed to serve individuals with a lower level of need than current comprehensive waiver. Many states put a person per month cap on their community support waivers. The recommendation from the special committee was $20,000. They also have a different array of services for community support waiver than the comprehensive waiver. The community support waiver does not have services such as overnight attendant care, residential or day services. Emphasis on services such as supporting employment, as well as respite, training, and personal care options. So the suggested services array from the 2022 Special Committee were transportation to and from work, supported employment, staff support with employment, individual directed goods and services, giving budget authority to the person so they can purchase goods and services as they will assist the person in meeting their goals, Personal care, individualized one-to-one services provided during times when the participant is not typically sleeping and to assist the activities of daily living. Respite services to give families time off from caring for their loved ones on the waiver. Potential therapy services could be talk therapy, cognitive or behavioral therapy, etc. Assistive technology, technological devices and programs to make the person more independent. Family caregiver support and training, parent support staff, trainings on diagnosis, etc. Financial management services and support brokers, assistance with personal budget and expenditures, benefits counseling, navigator to help person and their family understand Medicaid in Kansas. KDADS also anticipates that there will be an increase in the number of people who will self-direct their care. This will provide beneficiaries with more autonomy when choosing respite and personal care services. KDADS also anticipates that participants who are currently on the IDD waiver that do not utilize day or residential services may choose to transfer to the community support waiver, as they will have the option of individual budget authority. Individual budget authority will allow the participant to purchase services in the waiver to tailor services specifically to their distinct needs and preferences. That shift would free up slots on the current comprehensive IDD waiver for participants who would benefit and may need day and residential services. Now that we've talked a bit about the who, what, where, and why, let's go into the how and when. So we already have work underway with our partners that is integral to development of the new HCBS waiver. KDADS has many large projects underway around implementation of the final settings rule, CDDO, TCM conflict of interest, MFEI tier rates, and changes to the comprehensive IDD waiver, such as unbundling of certain services and building the provider network. Final settings rule refers to a CMS directive protecting the rights and choices and guarding against institutionalization and isolation of those served within the HCBS system. Final rule aims to ensure the individuals receiving long-term services and supports through HCBS programs have full access to benefits of community living and the opportunity to receive services in the most integrated, inclusive setting appropriate. The work KDADS and providers are doing will enhance our ability to deliver services on the community support waiver in the most integrative and inclusive setting. CMS notified Kansas that within our current IDD waiver system, in which the CDDOs help determine eligibility, that the entity determining eligibility should not also be providing services. The same is true for targeted case management. If you are providing TCM, you shouldn't be connected to a provider, as that might impact how choice is given to the participant. KDADS is working to resolve this conflict of interest by working with stakeholders, CDDOs, and contracting with the National Association of State Developmental Disability Directors. Moving away from the basis assessment as recommended by the 2022 Special Committee and to a strengths-based assessment. KDADS already has been working towards moving the MFEI as an assessment tool. This requires a lot of work, as the basis assessment is currently tied to tiered levels of funding for the comprehensive waiver, so we must work out a conversion from a tiered system with a new assessment tool for both the current comprehensive waivers as well as the new community support waiver. Important to use same assessment tool for both waivers. Other changes to current comprehensive IDD waiver up for CMS renewal this summer are unbundling of some services, expanding the provider network. Important to note that both the renewal of the existing waiver and the work towards the community support waiver development are occurring concurrently, so as not to delay the implementation of the community support waiver. Upon the recommendation of Senator Gossage, KDADS met with the Missouri State Waiver Team, which has been very helpful. Missouri has 3 HCBS waivers for individuals with IDD, a comprehensive waiver, a community support waiver that does not offer residential services and is capped at $40,000 per annum. Pathways for Hope waiver, which is capped at $12,000, but requires a 50% match of the state's obligation from counties who want to participate. It is not as simple as taking the Missouri Community Support Waiver off the shelf and plugging it into our system for Kansas. Missouri doesn't have CDDOs or managed care, authorizing HCBS services, which are both key components of the Kansas HCBS IDD system. Missouri's Community Support Waiver has a cap of $40,000, whereas our legislature has directed KDADS to cap ours at $20,000. This, excuse me, this directly impacts utilization estimates, cost neutrality, modeling, and how we design the overall service menu to achieve the desired results. Between Missouri and Kansas, there are also rate discrepancies, differing state regulations, network capacity, et cetera. Most importantly, and as required by CMS as part of the waiver development, is that Kansas has a very engaged stakeholder network, and we want to listen to their recommendations as we are developing the CSW. So the community support waiver timeline and next steps. In August of last year, KDADS received approval from CMS to use FMAP funds to hire staff and contractor for the community support waiver. The governor's FY25 budget continues this staffing with and adds additional staffing. Currently, KDADS has hired and is onboarding internal community support waiver staff. KDADS has developed a task order. We have reviewed the proposals in response to the task order, and we are now prepared to contract with one bidder. We plan to have the contractor in place no later than April 1. Using a task order did shave off some time when we compare it to the procedure for procuring an RFP. Our contractor will work to form and convene stakeholder groups to provide feedback to the state regarding services. Kansas stakeholders will drive the development of the community support waiver. They will work to develop the provider network necessary to provide the services, administer grants to help the providers get started with the new services, provide transformation grants to providers to assist them in modernizing the IDD service system and come into compliance with federal rules. Later this summer, the contractor will draft the application for community support waiver and work to expand the provider network. High staff turnover rates and consistent vacancies in the direct care workforce is one of the main challenges, both for the current comprehensive waiver and the new community support waiver. The challenge is not unique to Kansas and is being seen across the nation. KDADS has a number of initiatives underway to address HCBS workforce. As I mentioned before, we have the waiting list study for KUCDD. Will help us inform us on building a provider capacity in order to effectively reduce the waiting list. Direct service workforce training program allows training providers to apply for funding to create training and professional development for direct support workers. Training for IDD providers to support people with challenging behaviors. Throughout this entire timeline, KDADS, assisted by the contractor and stakeholders, will be working to build a provider network capacity alongside our current providers and welcome new providers interested in providing CSW services. This fall, there will be a public comment period as required by CMS. Kansas has many engaged stakeholders, and we want to be sure to include their input in developing this new waiver. The waiver application should be submitted to CMS, and then we have an anticipated 3 to 6 months to review the approval process. The process for the waiver implementation requires approval from CMS, and their requirements and timelines impact how rapidly the new waiver can be implemented. The 3 to 6 month review period by CMS is based on our recent post-pandemic experience that Kansas has had with CMS on various waiver amendments and renewals. no later than the final quarter of 2025, we want to begin serving our initial community support waiver participants. The development of the community support worker as quickly as possible is a major priority for KDADS and the administration, and we are eager to continue to progress. Thank you for allowing us the time to provide this update to the committee, and I am now available for questions.
All right, thank you, Michelle. Committee, are there any questions for Michelle in regards to the community support waiver? All right, seeing none? All right, thank you for being here. Next, we'll move on to the unwinding of the Federal Medicaid Assistance Percentage, or the FMAP. And so Christine Osterland, the Deputy Secretary with the Agency Integration and Medicaid with the Kansas Department of Health and Environment.
Good morning, everyone.
Christine.
Christine Osterland, Deputy Secretary for Agency Integration and the State Medicaid Director, and I'm going to give you an update of where we are on what is referred to as the unwinding. I do have a slide deck, so we'll talk a little bit about just the overview, timeline, kind of where we're at today, some data around unwinding, and then some process improvements that have happened, which not only have been beneficial for our members, but have really reduced some administrative costs for the agency, so kind of a win-win. So on slide 3, just a brief overview, because I know some of you, it's been a year since you've probably heard this update. The unwinding started April of last year. That was due to the omnibus bill that passed in December of 2022 that required all states to begin the unwinding process in the spring of 2023. Just a reminder that during the 3 years of the pandemic, from March of 2020 until April of 2023, Medicaid members, once they were enrolled, were not up for annual renewal, and they stayed enrolled except for very, very narrow circumstances. Kansas made the decision to do our renewals in chronological order. So whatever your annual renewal date was, that was the date you received your notification. And then another important factor to keep in mind is once a member receives a renewal, if they do not return that renewal timely, we will end their coverage, but then they're afforded a 90-day window to go ahead and submit that review, and their eligibility will be backdated. So what that means is if I sent you a renewal notice in April, you did not return it by the deadline, you would be discontinued as of May 1, but you have 90 days, which is the end of July, to submit that renewal. And if you were approved, you're backdated to May 1. And why that becomes important is when we talk about the data, there's a lag in really understanding how many members are going to lose eligibility because they get afforded an extra period of time in which to take an action, and eligibility can be backdated. So where are we with unwinding? Brief reminder is we started unwinding with about 540,000 members on our rolls. As of January 31st, our enrollment number was 487,000. So we were at about 62,000 individuals who had had their Medicaid indated. We have mailed, as of January 31st, 499,000 packets out to individuals. February was actually our last mailing. In early February, we did our last unwinding mailing, and that was for individuals with a March renewal date. So we now, as we are in March, the mailings we will start doing at the end of this week will be for folks that are past unwinding. These are April renewal individuals, but they had their unwinding last year, so this is like our continuous population. So from a mailing perspective, we have finished unwinding. Where we are with discontinuances is we have done discontinuances up through our November population. I'll talk a little bit about that lag between mailing and running a discontinuance. In mid-March here, we will do discontinuances for our December renewal population. So we've got about 4 months of our population which are past their 90-day window. Obviously, less than half of our population is past that 90-day window. Early trends, for those of you that remember, when we went into unwinding, it was difficult for us to estimate how many folks would come off the rolls just because of that 3-year lag. We had come up with a number of 100 to 125,000. We are trending to be probably around 110,000 that will come off the rolls, but again, with only 4 months of complete data, we don't want to offer that as an exact figure, but really as we get to the end of March, we'll probably be able to do our first really reliable trend of where we're going to fall within that range. From just a performance, some metrics here. So I think some of you remembered last year as you were in session and the unwinding was starting, there was a huge call volume surge that we did not anticipate. And you can see if you look on the bottom of this chart, the statistics at the end of April were terrible. They improved in May, they improved in June, but then our vendor quickly took some action, and we've been having very steady performance going through the unwinding. Importance of this means, if a member calls to, ask about a status or ask a question of what's needed, they're able to get through and have their call answered quickly and not spending large amount of times on hold trying to get help. So what's changed as we've gone through the unwinding that I think are a win-win for Kansas? One of the first things is our ex parte process. So what ex parte is when someone is up for renewal, we do a series of data matches on income, unemployment, citizenship, residency, vital statistics, death, those kinds of activities, assets, all kinds of data matches are done. And if we're able to determine through those data matches that the member is still eligible for Medicaid, we can go ahead and give them Medicaid for the next year without having to do mailings, have workers involved. So it reduces administrative overhead for the state. We were able to identify some improvements we could make in that process, and many of those have been implemented. We have some more coming this spring. One of the other things that we've done in the unwinding is much more use of automated outreach to members, text messages, emails, things that are much less expensive than sending mail or even phone calls for that matter. This is an opportunity to try to get them to respond. We're also doing a lot of activity around encouraging our members to create an account online, because if they will create an account online, we can give them their notices and we can reduce mailing costs and stuff, and also return mail coming into our mail room. They can upload documents in the portal. So it's really a way to automate and reduce some costs to the state, and also makes it easier and more timely for the member. One of the big wins I think that happened is, I'm not going to read all of these, but HCBS, one of the things that we discovered early on in the unwinding is, I think with the 3-year lapse, there were a lot of people that were not familiar with the renewal process, and we saw our HCBS members really struggle with getting their renewals in and getting their documents in. So KDHE partnered with HCBS providers around the state. We've partnered with KDADS, and we've been doing a lot of education and training of providers in an effort to provide more support to those members so they can not have disruption in care due to not getting information into the clearinghouse, which of course we know for that population that could be very catastrophic. On the next page, a few things that I'll mention here. There's been some, CMS has allowed the MCOs to have more involvement in the renewal process. That's another advantage to the state, because obviously they're talking to these members much more frequently than we are, because that's who they're going to for their care. And, to find providers, and so that was a way for them to help with the renewal process. We've been able to increase our penetration of telephonic signatures. That prevents us from having to send packets back out in the mail to get a wet signature, if you will. There's a process in line which is just recording their authorization of that signature. We've been able to used to be previous to the unwinding that if we were notified by the Postal Service there was a change of address, we could not accept that. We actually had to try to contact the member and send them a mailing to have them confirm that what they submitted to the post office was indeed correct. CMS relaxed that requirement, and we are now able to use that data. So before we send any mailing, we do a data match with the United States Post Office, and if there's an updated address, we're able to use that updated address, which has greatly reduced our return mail, which again is more timely processing. But the other fact about return mail is we're required then, if we get return mail, we have to then try to contact the member and send them another packet. So again, it streamlines it for the member, but it does reduce cost and staff time for the agency. The other, probably a big thing onto the final page that that's coming up is we are going to move the signature page in our renewal. One of the things that we identified very early on in the unwinding, depending on how large a family is, the signature on the renewal could be page 7 or 8 or 9 in the packet. A lot of people were missing it, and if they submit a renewal with no signature, we cannot accept it. We now have to take that renewal form, put it in the mail, send it back out to collect the signature for them to send it back in. Again, just a lot of administrative overhead. We are going to be moving that signature page up right behind the cover letter. So once they look at their cover letter, the next thing will be the signature. So our goal is that we'll get a higher volume of signed renewals, because if they don't complete anything else and they just sign it, we can work that renewal. So we're hoping that will be a big win for the state, both for our members as well as reducing some administrative overhead. And with that, that's kind of an update of where we are with unwinding, and I'll be happy to stand for questions.
All right, thank you, Christine. Committee, are there any questions for Christine in regards to the unwinding process? All right, seeing none. You're very thorough. Thank you. All right, committee, we're going to go ahead and move on to the next item on the agenda, aside from Medicaid. And that's going to be a discussion and an agency update from the Kansas Department of Wildlife and Parks. As you recall, when we had their budget, there was a motion to move that budget to omnibus, and we wanted to have more information by the Secretary and the Kansas Department of Wildlife and Parks. So I'd invite Brad Lovelace, the Secretary of the Department of Wildlife and Parks, to the committee. Welcome, Mr. Secretary.
Thank you, Chairman Waymaster, members of the committee. I'm really appreciative of the opportunity to come back before you and address some questions that arose in the budget report out on February 20th. Well, in the last few days, I've had the opportunity to meet with a number of you. Unfortunately, we haven't got to meet with everyone, and I apologize for that. The main question last week was on the Flint Hills Trail and associated with that, and I will address that here in a second. But first, I wanted to introduce two of my key coworkers in the agency. The first behind me is Martin DeBoer. Martin was sitting right there last week. We are very happy that he's come to join us as of Monday as our Manager of Government Affairs. His knowledge of policy and procedures has been invaluable already, and we really appreciate having him and believe he'll make us a much better partner with you all here in the legislature. The second key coworker is Linda Landerman. Next to him, Linda, even though it may not appear this way, she's been with us a long time, and she is a very energetic and expert division director of our Parks Division. She has been recognized both in Kansas as well as nationally by her peers as a great leader in the Parks Division, so I'm glad to have them here with us today. The main question, as I said last week, that came up was about the Flint Hills Trail. I want to give you a little bit of background with that. The agency was awarded a grant from the National Highway Administration to be used for the Flint Hills Trail project. The grant requires a $3.0 million state match that we would draw down, enable us to leverage the $24.8 million in federal funds. However, the state match is required as an upfront cost to the agency. We began work on the Flint Hills Trail in 2014, and it currently runs from Osawatomie to Council Grove. The RAISE grant that we just recently received will enable us to complete the 118-mile trail clear out to Harrington, which will be its western terminus. With the numerous grants that we've used, and all of our divisions use grants extensively, And we've used those over the years, but our match has always been allowed to be paid in increments. So we were surprised to find that the National Highway Administration wanted all $3 million for our match up front, despite the fact that we have clear till 2031 to complete this project. So during conversations with the governor, it was suggested that the funding for this match ought to come from state general fund because of the important economic impact of these trails and our parks, and also our limited park fee funding at this time. And so we really appreciate that consideration and believe that it'll be a great economic boost when we're able to complete the Flint Hills Trail here in a few years. So with that, I would be glad to answer any questions.
You just kind of opened yourself up, didn't you? Committee, are there any questions for the Secretary? Representative Corbett.
Were you going to announce your retirement while we're all sitting here?
No.
Okay.
I am looking forward to retiring soon and us getting a new secretary here maybe in the next few weeks, but it's not official yet, so I can't say anything.
So the question I have with the data you just gave us, you want about $28 million to do 118 miles of trail. Is that what you're saying?
Actually, the $24.8 million is a federal match. We have the federal match to our $3 million state match. That'll enable us to complete the last 40 miles. We're up to Council Grove now. We want to go clear out to Harrington, and so that'll enable us to get from Council Grove to Harrington and complete the whole trail.
And I may have divided that wrong, but you're averaging about $200,000 a mile. That's a pretty good trail.
Yeah, it's expensive. The things that are particularly expensive when it comes to that trail are crossings. We have to cross the railroad in places, and all of you know how complicated and expensive that is. While it's an old rail trail bed, and once we get it completed, it'll be very stable, low maintenance, but there have been several places, because it hasn't been used for decades, where the culverts have become in disrepair, and so we've had to replace culverts, which is another expensive part of that. But the good news is when we pay this match, that's the last significant payment we'll have to complete this trail, and it'll be 118 miles long, as I said. It's a great resource, already attracting people from all over the world to use it.
Mr. Chairman?
Well, I just want to interject. So just to clarify, and I had questions about this myself. So the $3 million state cost share draws down $24.8 million from the federal government. Correct?
Correct.
Representative Corbett.
So, so basically, for the other way you pay for your trail projects is comes out of the park fee fund?
Correct. That's the main way we pay for all our parks projects, and we use that park fee fund that comes from camping fees and things like that to leverage federal money to do all these projects.
But on the other side of it, there's no fee for the people to take the trails. The park people are paying the full load on it, it sounds like.
Yeah, that's exactly right. Given the length of the park and there's access everywhere, which is the way we wanted it, make it easier for people to use it, but there's no good way to charge people. So we hope that they get a park pass to go into any of our state parks, but that's not required to use the Flint Hills Trail.
Thank you, Secretary.
Thank you.
Representative Hoffman.
Thank you, Mr. Chairman. Now, I understand the $3 million was for the cost share, but in the budget, wasn't there also another $3 million that was added on?
That was kind of confusing. Another
Okay.
part of that trail is an expensive. I mentioned railroad crossings. We have another part of the trail that we got a separate grant for $3 million to do a railroad crossing, and that cost share is $300,000. That comes out of our park fee fund, but that is actually for part of this trail that we consider separate from this last 40 miles.
Representative Hoffman.
Okay, so it's 3.3 million, and that's all the SGF. Because I thought I was understanding it was like 6 million SGF, so it's only 3.3 million SGF.
Absolutely.
Okay.
Right, absolutely correct.
All right. Do you want to take questions about other things or just the trail at this point?
At your pleasure.
Proceed.
Okay. All right. As far as the park fees, you know, we were looking and I think you kind of explained that maybe between I-bars and the way you guys look at things, it's not quite as bad as what it looked like, but the fees do seem to be, or the balances seem to be going down quite a bit. We talked a little bit about park fees. Oh, thank you. Where are we at on that?
We're having conversations with our commission about if we ought to be adjusting those fees. In the last several years, you all have seen this driving down the road. They aren't those small campers like they used to be. They're big. And lots of times, even the new ones have 2 air conditioners. When they come into our parks, the fee that we've always charged includes all their utility usage when they're there. And since 2015, the usage of utilities by folks in our parks has increased by about 68%. The cost of those utilities have increased by about 48%. So that's all been absorbed in our current fees. And so we think it's definitely worth a conversation with our commission about if we can adjust those. Another couple reasons why we think it's important to consider adjusting those fees is because our market rate, we need to keep close to that market rate. There are private campgrounds out there. I know some of you use those campgrounds. In the past, when we drifted low, we got comments from them saying, hey, you're undercutting me. So we want to stay even with those to be a good neighbor to them also. So 2 good reasons why we need to adjust those fees periodically.
Yeah, I think they probably ought to be adjusted pretty quick because as we talked about, I stayed out there out at Canopolis. It was like $24 a night, and we were using a lot of electricity that night.
Right.
You know, we had the heater going and all. Well, that didn't quite come out exactly the way I was expecting. Yeah.
It turns out they aren't going to let you in Canopolis anymore.
What's that?
It turns out they aren't going to let you in Canopolis anymore.
Yeah, probably not. Yeah. No, but it was only like $24, and yeah, I really think I'm not sure now. I had, you know, of course I have a year permit for my vehicle already.
Right.
But still, I'm not sure that I could have stayed anywhere else for that amount. So it's something we really do need to look at really quick, I think. Yeah. So thank you, Mr. Chairman.
Agree. Thank you.
Representative Owens.
Thank you, Mr. Chairman. 2 things. First of all, one of the items in the budget we never had a chance to really dig into, so I'm glad that you're here and I get to ask this question, was changing the deer season to establish that to November 28th of 2025 as the first day. Can you address that? Was that a recommendation by the board, by the professionals that know how to manage these herds, or where'd that come from?
Yeah, thank you for the question. That wasn't a recommendation by our biologist, and we're concerned about that because we have a trophy deer population in Kansas. It's a destination place. If you look on the hunting channel, you'll see, you won't go through very many portions of that before you'll see Kansas come up. Everybody wants to come to Kansas and shoot a big buck. One of the reasons why, well, 2 big reasons why we have the trophy population we have is we carefully manage that in populations based on units around the state. And the second reason is early on, the people before me had the wisdom to push the firearms season outside of the rut. The rut typically occurs about mid-November here. And during that time, deer, especially those big bucks, have their mind on things other than their own safety. and
True that.
And they are very susceptible to hunters. And if you have a rifle and can shoot them with a rifle, they're especially susceptible. So by pushing the rifle season past the rut, well past it, we've been enabled to keep this trophy population, develop it and keep it. And so we think moving that closer to the rut, as was suggested in that amendment, would be a mistake.
Representative Owens.
Yeah, thank you very much. I appreciate that clarification. And Mr. Chairman, and I don't know if this is the right time to make a motion, not as it relates to that specifically, but today I would like to make a motion, if it's possible, to go ahead and move working this budget to the mega bill so that we actually work it tomorrow or the next day to ensure that this agency is part of this initial budget.
I would say that's in order at this point. I was going to go ahead and wait till we actually opened up the budget, but since you're wanting to go ahead and make the motion, I'll go ahead and accept it. So we have a motion, and then seconded by Representative Landwehr. Discussion on the motion. Representative Landwehr.
I can say yesterday, Mr. Chairman, I had a very good discussion with the secretary or whatever, I'm sorry, your title. And I think it put some, of my concerns at ease of clarifying this budget a little bit more. And I did tell him that a caveat when we get to that budget is to put wording in there that they start looking and develop, at least a 5-year, if not a 10-year plan to figure out what they're going to do. How do they need to adjust their rates? What can they do to promote their different seasons? Because like last year, I believe that they cut out the turkey season. Well, that cost money to us, so thank you.
All right. Any further discussion? Representative Corbett.
I agree with probably punting this to the next deal, but one thing I want to bring up to the change of the deer season. Can we talk about that a minute, Chairman?
We're actually on the motion of moving the budget into the mega budget, so I'd rather just stay on that.
Okay.
Any further discussion on the motion by Representative Owens? All right, seeing none, Representative Owens, you may close.
I close.
All right, committee, you've heard the motion. All those in favor of the motion say aye.
Aye.
Opposed? All right, motion passes. I'll come back to you, Representative Corbett. Representative Carlin.
Thank you, Mr. Chair. I think we moved too quickly past all the things I wanted to comment on at the time. I do think that, I just wondered when we were going to work the budget and a few other things, but I didn't get to see you, so I'll wave louder. Thank you. Nothing right now.
All right. Representative Williams.
All right, thank you, Mr. Chair. So thank you for clarifying a little bit on the Flint Hills Trail and the 3 million and so forth, but can you talk just really quickly about the long-term plan for the Rails to Trails in Kansas? You have the Prairie Spirit Trail, that's finished, completed. If you look at Missouri, they have the Katy Trail that goes across their entire state, which is 200 plus miles. I don't know that we have anything that's contributed either through the Wildlife and Parks or through KDOT locally where I live. There are Rails to Trails projects. So what is the plan? Is the plan to connect? And so will we see continued maybe federal and state funding for these Rails to Trails projects?
Yep. Thank you for that question. We do have visions. We'd like to move the Flint Hills Trail connecting it east with the Katy Trail. Currently, it's the 5th longest trail in the United States, but of course, when you connect these, then it benefits everyone. And so we have that in our plans. We're trying to figure that out. It gets complex, no surprise, as we go through Kansas City and that area, but we're working on that. We've been approached by folks from Junction City about taking a trail down to connect with the Flint Hills Trail in Harrington. And of course, as you mentioned, in a lot of our communities, they're doing small segments of projects that benefit that community, but we have been partners with them for years trying to help them connect those segments together to add to the value of those trails. So we will continue to look for those opportunities. Oftentimes they come first from the communities who say, we're limited down here in what we can do. Can we partner with the state to do this? And we're glad to partner with them.
Representative Williams.
Yeah, and just in closing, I think that this is such a great use of money. I know that property rights is always a concern, but the railways were already coming in the right-of-ways of people's properties, and it's such a fabulous way to get people outdoors. Thank you.
Representative Corbett.
So, Secretary, how many years has the trail program been in effect?
Well, the Flint Hills Trail started in 2014. We've worked on other segments of trails for a long time, but since 2014, Flint Hills Trail.
And do you have any data to show how much activity, how many people have ever used these trails?
Yeah, I'm not sure that we've ever put counters. Oh, Linda saying we have? We have some of those data. Can Linda address that?
Yes, please,
Our
Linda.
expert?
Please identify yourself for the committee.
Thank you, Mr. Chairman and members of this committee. Linda Lannerman, Kansas State Parks Division Director. We do have some counters. We could do better, but the reason you asked about having a trail fee, we used to have a trail fee. We did not see much activity. It was hard to enforce. And so the communities came to us that that trail went through and asked us to remove that fee so that we could have more access. People could get on those trails. And keep in mind, these trails provide a significant economic impact of those communities it's going through. And so we do have a counter system where we are able to get visitation off of that, as well as in our other state parks.
Representative Corbett.
Mr. Chairman, the thing that frustrates me a little bit about the trail program is you expect other permittees like the parks people or everything you use in the state, you've got duck stamps, deer stamp, you've got license for every critter you've got except a trail person. And it seems like if you want your parks to grow, you need to be able to keep all the money you can get in that. But it seems like there's no program in your foresight for these hundreds of miles of trails to keep them up and how to pay for them.
So we have a system of state parks. Not every one of them supports itself. And so of that system of state parks, once that trail system is put in, their O&M part of it is very small. And we have staff that oversee that, but we use that staff other than just that trail. They're law enforcement certified or they're maintenance people that we can use. So keep in mind, it's a system of state parks. It's not just one state park we look at for that revenue. Thank you.
Any further discussion in regards to the budget for, or the, I guess, the Department of Wildlife and Parks? All right, seeing none. Thank you, Mr. Secretary, for being here.
Thank you very much.
All right, committee, it is about 10:35, and actually, I want to kind of commend Representative Owens. You kind of took care of one of the major items that I wanted to discuss when you made your motion today. So we're going to go ahead and start and open up discussion in regards to House Bill 2273, and that was the appropriations bill from last year that was inserted into Senate Bill 42, and that was the appropriations for fiscal year 24, 25, and 26 for various state agencies. So I would entertain a motion to open up discussion in regards to House Bill 2273. Representative Hoffman.
Thank you, Mr. Chairman. I move that we open up 2273 to work on it.
All right, you've heard the motion. Is there a second? Seconded by Representative Helgerson. Do we have any discussion this morning in regards to House Bill 2273? I would probably just say we will recess in regards to the discussion on the budget bill until tomorrow morning. So get your amendments and your provisos ready. And then we will resume discussion on House Bill 2273 for our budget position at 9 a.m. tomorrow morning. So until then, oh, I also want to make an announcement. Thank you to Representative Landwehr for providing us with breakfast. So if you haven't received yours, it's over on the left side of the committee room. So until tomorrow morning. No, we had the motion by Hoffman and then seconded by Helgerson. So until tomorrow morning at 9 a.m.